Okay, we're going to get started. Our next topic is on speech and swallowing. As promised, we have a dad joke for every panel. Promise the very last one. Why did the Scarecrow become a great public speaker? Because he was outstanding in his field. Okay, we have an excellent panel today on speech and swallowing and Parkinson's. We have Terry Kennedy. Terry is a speech language pathologist, the owner of Speech, Swallowing, and Voice Specialists. She specializes in Parkinson's disease or dysarthria, dysphagia, which is swallowing, orofacial myofunctional disorders. That is a mouthful. She has advanced training in flexible endoscope evaluation of swallowing, which is an instrumental swallowing assessment that can be performed in the patient's home. She's been practicing as a speech pathologist for 20 years and has worked locally in hospitals, skilled nursing facilities, assisted livings, and home health agencies. She started her private practice in 2020 after working with those with Parkinson's disease, realizing the need for specialists in the field. She's recently joined the Hawaii Parkinson's Board to help spread the message to everyone that you can live well with Parkinson's. Thank you, Terry. We also have Stephanie Mullen. Stephanie, if you can raise your, thank you. Stephanie is a speech language pathologist practicing since 2007. Originally from Chicago suburbs, she now calls Big Island of Hawaii her home. She takes pride in providing current research-based care with interprofessional collaboration to ensure all options are considered to help clients achieve their goals. Through her compassionate, client-driven sessions, she guides many individuals to regain and maintain their ability to swallow, communicate, think, and remember. Stephanie received the Parkinson's Voice Project grant for 5 years in a row, yay, 2019 to 2023. She hosts a free weekly maintenance speech group for Parkinson's called Speak Out, and hosts free monthly talk story groups for individuals with communication and cognitive challenges. Historically volunteered on Educational Affairs Committee for the Hawaii Speech, Language, and Hearing Association. She is an active member of the Speech Medical Caucus for Hawaii. She hosts graduate student clinicians and is a preceptor for new hires in home health care. After years of attending Hawaii Parkinson's Symposium, she is honored to participate. We're honored to have you as well. So, thank you. And last but not least, we have Joanne. Joanne is a licensed speech language pathologist since 1991, whose clinical specialties include swallowing, communication with adult populations. Joanne is adjunct faculty at the University of Hawaii Communication Sciences and Disorders, and has experience with classroom instruction, clinical supervision in the university's speech and hearing clinic. She continues to serve as a liaison between UH CDS program and Queens Medical Center, working with student observers whenever possible. Joanne has co-authored research articles and has written a book chapter regarding speech communication. In addition to teaching, Joanne's work experiences include service provision in acute care, skilled care, home care, and outpatient settings. In her free time, Joanne enjoys reading, cooking, and finding creative ways to reuse, reduce, and recycle. All right, thank you for that too, Joanne. Okay, as we did in the other panels, I'm going to start with some questions that were submitted, and then we'll open it up for the audience. And I think what we'll do is, so we're not having our microphone person get out of breath, we'll start on this side of the room, and then we'll listen from the other side. So. Okay, first question. The Parkinson's Foundation states that 89% of people diagnosed with PD will have speech issues. If I do not have speech issues now, are there things that I can do to prevent this from happening? Or is it just inevitable?
Okay, I guess I'll answer. So speech issues for Parkinson's, I wouldn't say, we really don't have a crystal ball and can say anything is inevitable, but with that percentage, yes, there are speech or voice issues that are going to occur. What we're hoping is that at the diagnostic level, you go see a speech pathologist. So when you are diagnosed with Parkinson's, you need a baseline evaluation to see what your voice is like, to find out, in fact, is it just you getting used to the changes that are due to Parkinson's, or are you having issues maybe your partner's seeing that you're not seeing? We want to kind of show you what the signs and symptoms are. And if you don't need us, then we send you on your way, and then you come back when you do have issues. So I would say with that percentage, there are going to be speech issues out there, and some of these other questions are going to kind of help us unfold what those issues are to help you be able to identify. Anybody want to add to that?
I think that if you are referred for an evaluation, please come, because we may identify some things that may be bothering you that you don't really realize, or other people have been telling you, because you're thinking, well, everybody else has gone deaf because they keep telling me they can't. What? They keep saying that. But sometimes it's something else that we can address and help you manage.
To add to that, I think that everyone that sat up here and is in the perimeter tables is emphasizing that even though we may be developing symptoms, there are options and things we can do about it to use and regain, use and maintain our ability to communicate and swallow. So if it's inevitable, we won't know until time passes and we find out, but let's do something about it now together so that we can hold on to that ability as long as we can through different exercises, activities, and coming together.
And I did just want to add right quickly, they had mentioned a second in the last group about constipation, and 2 days, 3 days, but when you get to 5, 6, 7 days, we have a bigger problem, right? So with your speech issues, we don't want to wait till it's a big problem. We want to see it while it's still a little problem, because it's a lot easier to fix a little problem than a big problem, right? So in regards to prevention, yes, we can try to prevent some of the deficit from being so extreme, and then again, like Stephanie said, help you maintain that function.
So I'm going to combine two questions here. So if I occasionally choke when drinking water, do I need to be assessed for swallowing? And what is causing that swallowing disorders for Parkinson's?
Okay. So yes, a lot of Parkinson's symptoms are inconsistent. Sometimes you're walking fine, sometimes you're not. Same thing with the swallowing. Sometimes you're okay, sometimes you're not. It is not typical or normal to choke on your food and liquid. Parkinson's are not. What we want to see is this happening regularly, though. So a speech therapist, you would need to go see a speech therapist to see, what does occasional mean? Because occasional for me and occasional for you is something totally different, right? So we want to find out what's going on. And then yes, there is intervention that can be done for the swallowing. Parkinson's and swallowing issues are definitely high on the list. There's a 70%, mortality rate with Parkinson's, 70% is due to aspiration pneumonia, which is something going down the wrong pipe. So that's, we'll make that real simple. 10 people, 7 out of 10 people with Parkinson's are not dying from falls or other complications. They're dying from an infection in the lungs due to liquid or food not going down the right way. And those are things with therapy we can intervene and hopefully prevent.
And sometimes you can have trouble just managing your own saliva. And I know there's a question about that. Not only losing it out the front, but also just choking on it sometimes, just sitting down and not doing anything. So that's also another thing, too, we look at as well.
From that, I'm going to go to the next question, which is related. What is the treatment for swallowing issues?
So in order to answer a question about treatment, we first need to find out what we're treating. So I'm going to give a shameless plug for having your swallow tested with an instrument, whether X-ray or with a scope. And my colleague Terry here, I'm giving a pat because she is one of the providers here on this island and outer islands that can do that kind of testing. We don't have X-ray vision. We need to go in and take a look. Beyond that, we can also know within the brain how Parkinson's is affecting our swallowing because of the movements that swallow requires. And earlier was discussed as far as using intent while swallowing, and that taps into a different area of the brain than the automatic swallow, as you saw in the brain diagram that was up there just a minute ago. So in order to treat and help get beyond those symptoms of difficulty swallowing, we're first going to take a look at where is that underlying root cause, and then combine what we know about movement in Parkinson's benefiting from using intention in addition to specific exercises for whatever area in the swallow is causing the trouble, either chewing, swallowing, coughing, dribbling, etc. So there isn't a quick Band-Aid approach is the short answer. It's very individualized, and that's why you need to meet a professional that has that area of expertise specifically. Hopefully someone who has experience with Parkinson's as well.
And if you do come to the hospital for an X-ray swallowing test, you might have heard about them. They're called modified barium swallow evaluations. But what that is it's nothing scary. You don't need to starve beforehand. You just we make an appointment and we see you in the clinic beforehand, and then we just give you some things to eat and drink under X-ray so we can see where things are going. Because Stephanie was saying, we don't have a crystal ball. So we do X-ray swallowing tests, and then Terry also does, we do it as well, but not as much. Terry also does a different kind of swallow test that involves what we call a fiber optic endoscopic scope that she puts, well, Terry will explain it to you, but it's another way of looking at what's going on because we can't just guess. Your health and your life is too important for us just to go, well, I think it's this. We need to see and make sure.
So yeah, the short and sweet of my test is it's an endoscope, has a camera and a light, very tiny, goes in through the nose, hovers over the back of the throat, does not hurt. I've done it to myself, trust me. And it's 10 minutes in your home. So it is performed in some of the hospitals, but my practice, we actually come to you. That way you're not waiting long lines or waiting for an appointment that may take months. It takes about 10 or 15 minutes, and then I get a clear picture of what the issue is. But kind of coming back to the, can we do exercise? Can we fix this? With swallowing issues, we can manage it, but we can treat it. And so you want to make sure your speech therapist is a Parkinson's-focused speech therapist because you don't want to just manage it. Managing is just kind of sometimes slapping a Band-Aid on it and being told, well, you just have to change your diet or you just have to, not eat this or not drink that. We don't want that to be your only course of intervention. A lot of our practice is exercise-based. These are muscles. There's 50 pairs of muscles, there's 10 reflexes. All of these things are part of a 1 to 1.5 second swallow, right? So there are a lot of parts of the body that we can work on to improve that function. And then the slide we had up before was about the brain, and that just, again, shows the intent. They said that earlier, intention, exercise with intent, exercise with focus. Parkinson's rehab is exercise-based. It's twofold, exercise-based and retraining the brain to send these like the doctors were saying earlier, these automatic things that used to be automatic, making it manual now, really doing something with intent.
Okay, one quick question. Is the endoscope covered by insurance?
Yes, the endoscopic evaluation is covered by insurance.
As well as the video fluoroscopic swallow study that Joanne was mentioning.
Great. Okay, one more question, then we'll bring it to the audience. Why do I drool, and what are some things I can do to decrease or stop that?
So that's a tough one, but sometimes it has to do, you're not necessarily making any more saliva than you have in the past. Sometimes, again, it's just that swallowing is automatic, tends to be automatic, as is blinking. And the automatic system in Parkinson's is what gets affected. So we're not always swallowing as often as we might have before, as well as not blinking as much as before. Also posturally, with Parkinson's, the posture can change. And so when that happens, when we start different head carriage, different body posture, the lips don't always stay closed So when we come forward or leaning forward, the lips pop open. And if there happens to be saliva still in the mouth, then you can kind of lose it out the front or the side. Add more.
So let's just try that now. Let's put it into practice. Go ahead, get the saliva that's in your mouth and swallow with intent. Like you mean it. With purpose. Did it work? And sometimes with Parkinson's or aging in general, we then have a little more difficulty with our attention and memory. That adds another layer of challenge, because if we're highly focused on something else, like writing down an appointment, or opening the pill bottle, or walking with our walker, which direction did gravity take my head? Down. If our lips are open, where is my saliva going to go? Out. Right? And so other Parkinson's plus conditions can also have a backwards position, which is not as common, but sometimes, or if we're sleeping, we're not automatically swallowing as often, we might find that the saliva is dribbling back, pooling, causing coughing, throat clearing. So that's something you can have in your back pocket, your freebie for today. Pull it out anytime you need. Swallow with intent.
Great. So let's take some questions from the audience. So we have a microphone. Oh, coming. Just.
I had a question. If you have Parkinson's and you have no noticeable swallowing or speech issues, will insurance cover for just simply a screening exam?
Yes. An evaluation, insurance will cover an evaluation. So you come, you let us know, I'm not having any problems, I want to have my baseline at least, and then we'll at least have something to refer back to for you to compare, right? Now I think I'm having a problem. Oh yeah, let's look back and see. And so that's why we do encourage, when you're diagnosed, even if you think, people understand me, I'm not drooling, I talk okay. Come in anyway, let's do the evaluation. Our goal is for you to fire us, right? We don't want you to have to use this. We rehab people. We want to be able to fix something and set it free, right? So we're not going to make you do therapy if you don't need it, right? But with Parkinson's, we know education is huge. That is key. Knowledge is key. So you coming to see us, that's an informational session. We get the baseline, and then we give you those red flags, all these things to be on the lookout for, and to know at what point is it a problem that I need to come back and see you.
And hopefully, if you're working with your neurologist, every 6 months to 8 months or so, whenever you visit them, they'll maybe hopefully will send a referral to physical therapy, occupational therapy possibly, and then also speech and swallow, just to be in front of things. So periodically, there ideally would be some reassessment all along the way.
And we, or at least my practice, once you come and we work on speech or swallowing with you, I actually do set that up. And it is case by case. It's not a cookie cutter formula, but I might meet back with you in 3 months just for a little screen. Hey, how's everything going? Or 6 months or 9 months or a year, because we know that Parkinson's is progressive and we're gonna have some change, right? And then that way you at least get face to face with a provider and can say, nope, I'm good, I'm not having any changes, or yeah, after all, there is something that's different. Should I be worried?
Any other questions from the audience on this side? Yes.
Okay, the question I had was related more to, I guess, gut health, but then gut health starts in the mouth. Can you comment on that a little bit? I don't know if a dentist should or what, but could you comment on that? Thank you.
I'll do my best because I'm not a dentist. I'll stay in my lane as a speech pathologist and highlight the importance of oral health, meaning let's brush our teeth, keep hydrated. I'm going to echo that over and over with my colleagues as well, how important it is to have enough hydration and water, because if we don't, then we won't have enough saliva to moisten our mouth to communicate. And with that, if we get a film in our mouth, then it's already building bacteria. That bacteria and the plaque that is on our teeth is not only going to be our highest risk related to acquiring pneumonia. I'll say that again, having a bacteria in our mouth, which we can prevent with brushing teeth, is our number one defense, to brush our teeth to prevent that acquired or that aspiration pneumonia that was highlighted in that mortality rate. With that, it's all connected. So it will positively affect our gut health as well. And then I'm stepping into the dietetic and the GI lane. So I'll go ahead and defer to those experts to further answer that type of question. But I just want to reiterate oral health, oral hygiene, make sure we're brushing our teeth. And now, as my dentist even told me the last time I was in for my cleaning, to floss and brush before I eat. I thought I would get that reaction, and brush and then use my dental floss with the toothpaste foam on my teeth still, so it gets up in there between my teeth to really clean that area. So I thought, oh good, I'm telling my clients the right thing if my dentist is then telling me to do the same thing, especially because, well, I'm over 40. So that was his way of jabbing on my way out, saying, like, us older people, we need to brush and then floss that toothpaste up in there and keep it clean. And that's also linked to cardiovascular health, which our doctors will be able to expand on in their area of expertise as well. So it's all connected. Shameless plug, brush our teeth.
Say that again?
He says spit is good.
So it has enzymes in it to help break down food. So that will help your GI, it's like she said, it's a system, right? So the more you're chewing, the more saliva you're making. The more saliva you're making, it's helping with that food breakdown. You will all notice you do have a toothbrush and a pamphlet in your bag that talks more about this. If you were wondering why the speech therapist gave you a toothbrush, she just went in detail about it. So if you want to read more, you can look at that pamphlet as well about that.
And so what it all means is make sure you brush your teeth before breakfast. You can brush after, but make sure you brush before, and make sure you get your tongue. If it's really hard because you're worried about gagging, don't brush back and forth like this. Come from the side and come down. Okay, and you can kind of get a little further back each time, because sometimes people will gag this way.
All right. A lot of good tips. Any other questions on this side? No? How about on this side? Any questions? Yes. Microphone's coming.
So you mentioned about intentional swallowing, right? And if you're drooling while sleeping, obviously you can't do that. So any recommendations around that?
So the drooling while swallowing, what I first picture is you're sleeping with your mouth open, right? This, I do try to help patients with this a little bit. It's case by case. So with Parkinson's, you can have sleep apnea. There's two different types: central sleep apnea, obstructive sleep apnea. With the obstructive sleep apnea, sometimes we have patients with their mouth open, right, while they're sleeping, and the drooling is happening. There's weakness in those muscles, and we try to help retrain those muscles to come together. But the intentional swallow part, you are correct. Because you're asleep, we try to strengthen the muscle to keep that mouth closed, but you're not going to be thinking about it. And so for those, it is more of a managing thing. For example, if you're drooling or you're not swallowing intently your saliva and you're laying back, I have a lot of people that say, oh, I'm choking on my spit at night. We may position you a different way so that you don't have that issue. And then other things to keep in mind is some people have BiPAP, CPAP, so those have to be considered in trying to manage that nighttime drooling.
There is some things that we can do called myofascial stretching that has to do with just making sure the tissue layers are just nice and supple and movable. And so sometimes we'll do some of this, we can teach you some stretching for the muscles as well as some kinesiology taping. I know that's a whole other thing, but sometimes they're not tape over your mouth, but there are ways to help support the lips coming together and staying closed. There are ways to do that as well. So speech people do that too.
Great. Any other audience questions? Yes, over here.
Hi, would you recommend that everybody get the pneumococcal vaccine for pneumococcal pneumonia? I would.
I'm going to refer to the doctors, physicians for that one.
I would also like to comment there are different types of pneumonia, and the pneumococcal pneumonia is different than an aspiration pneumonia. So maybe it would be helpful if we just clarify that aspiration pneumonia, aspiration meaning going down the wrong pipe, means going into the lungs, whether it's saliva, drinks, food, pills, particles from the air. The only thing that should be going into our lungs is air. Yes, air. So if anything else goes down and carries bacteria with it, that puts us at a risk for aspiration pneumonia. So we are probably not the most qualified, and we'll defer to your physician to give the best advice for the vaccinations.
Okay. Any other audience questions? Okay, here's another question that was submitted. Will my Parkinson's medications help with my speech like they help with my moving?
We can. Yeah, go ahead. Intention.
Go ahead.
No, go ahead. Yes.
Sorry, we did not figure out who's
Yeah.
going to answer what. We were just
We'll just all
playing it by
talk
ear.
together, yeah. It will, because it helps with the dopamine substitute, I guess, like not a replacement, but, the dopamine again is a neurotransmitter. All of that, it just helps everything move better. And so with intention, in addition to medication and exercise and everything else that we talked about, good nutrition, good hydration, yes, things can be better.
Okay, next question.
Can I expand on that
No,
just
you
a little
can't.
bit?
No, of course.
Shucks, I missed my opportunity. I love the banter, thank you. So yes, I think we would all give that resounding yes, and it is patient and person specific, as well as the dosing, the timing is also person specific. And I appreciated earlier the comment about thinking intentionally about pacing our day when we take the medication, when we eat, when we do our activities of daily living, when we exercise, and thinking about our bodies like a battery and knowing when our prime time is for our medication, because some people experience that time on and time off, a prime time. Sometimes it is a nice, easy, smooth transition throughout the day. Some people have a very clear time on and time off. And so with that, talk with your specialists in whatever is coming up as a priority or a struggle to help figure out that routine. And it'll also help to identify any changes in your body, in your system, and when is good to go back and talk with your doctor to adjust things, because it can help catch those changes in body systems or symptoms or the progression of the process in Parkinson's.
Okay, this is a good one. My wife constantly complains that she can't hear me. What can I do?
Huh? What was that? Say that with more intent.
You got to answer it.
So you need to see a speech pathologist is the simple answer there. A lot that I don't know if we can count how many times we've heard this. My spouse can't hear, they never listen, they have selective hearing, which still may be true. But if you have Parkinson's, you might have a little part in that communication issue as well. So those are these red flags that we try to teach you about at diagnostic level when you're diagnosed. When you start hearing your spouse saying, I can't hear, that should be a red flag. Go, let me start to see, is this a problem? You know, am I starting to have some of these other symptoms? But yes, that is enough to warrant going to see a speech pathologist. Any breakdown in communication, any breakdown in swallowing, a breakdown in cognition, these are things you say, hey doc, I think I need to go see a speech pathologist and see if there's an issue. Again, if there's not, we will let you know. Well, but if it is, then hopefully you've caught it early enough so we can make improvements faster and then be able to maintain that progress.
It's kind of related to that too. Somebody's asking about amplification, if those are devices they can use to help them sound louder. And would you recommend it?
Do you want to answer me? There are devices that help for amplification. I do not recommend doing it until you've gone to see a speech pathologist. Again, that is managing a problem versus intervening or treating it, right? So there are other options. I mean, I would much rather just be able to walk around and talk. If I had to walk around with this mic for the entire day, right? Think about it. I had to carry it everywhere I went just so people could hear me, how cumbersome that would be. All the things that go along, check the batteries, all that kind of stuff. Much easier just to open your mouth and it come out, right? So speech pathologists having that assessment, we can see if we can make improvement. And we know as speech pathologists that specialize in Parkinson's, we can improve your volume. We can. There are designed programs to help specifically with Parkinson's, which is why, again, we really stress finding a speech pathologist that knows about Parkinson's. So if you don't come to see us, that's fine. But when you go find your speech pathologist, ask them, do you treat people with Parkinson's? Yes. Can you tell me about your program? And if they can't give you a clear-cut program, then you may want to reach out to someone else who understands the disease a little bit more and go that route.
Yeah, the question might be to your speech pathologist, how many Parkinson's patients do you see per week on average? Then you kind of get a good idea, a good feel of if there is a specialty there. But then also too, if there is a need for amplification, there are things that are available and your speech pathologist will be able to help recommend something that is good for you, because sometimes by the end of the day, if there's not a whole lot of energy left and your battery is drained, you do need a bit of help because it's just hard. So there are options out there.
So there are a couple of speech programs out there nationally, Speak Out, LSVT Loud. Can you talk a little bit about what's behind that, or what's the principle of those programs?
Me? Okay.
Can we see the previous slide with the brain?
So LSVT is one of the programs, Lee Silverman Voice Therapy, and Speak Out. Through the Parkinson's Voice Project. Those are the two primary programs that are designed for Parkinson's patients. All speech therapists learn. She put it great the other day, we all have a class about Parkinson's in graduate school. A class. Not the whole semester, like a class in that semester, right? So we learn a lot after we decide what area we're going to go into, right? So everyone knows a little bit about Parkinson's as a speech pathologist, but those two programs are the ones that have been designed to really focus with the Parkinson's community. LSVT focuses a little bit more on loud, right? Big and loud, you've probably heard that. Speak Out focuses on intent, right? So you've heard both of those probably with different exercise groups and even here today. You had LSVT training. I had LSVT training. All three of us have had Speak Out training. I can't speak for these two ladies, but as for myself, I have been trained in both. I no longer offer LSVT. Nothing wrong with it. It's just I see faster results with Speak Out, and I see better maintenance. And so that's what I offer to my patients because I see that it works. And it follows this kind of design here of intent, right? So we improve with exercise the muscle strength, and we change your mindset to think more intentionally rather than automatically. And I have found that usually within about 3 or 4 sessions, I see probably 90% of my caseload is Parkinson's. So in about 3 or 4 sessions, the patients will see results. Now, it takes longer to carry over into every day, right? With me, it's great. And then they go back to their spouse and they're like, oh, they can't hear again, right? Or really, your voice has got soft. So it takes a little bit longer to carry over, but it has been very successful. And maybe you want to add more from your LSVT versus Speak Out what you think.
Mm-hmm. I think this is, if you understand how this works, it's kind of simple in that one system uses more dopamine than the other. And so if that's one area that is affected with you, then it's this other system, the less dopamine use. And that's coming from intention. When you use intention, you bypass the need for as much dopamine. It's a physiologic thing that happens in your brain. So it's not just, oh, think hard and it'll be better. There's a real reason for it.
And I do just want to kind of give credit to Parkinson Voice Project. They are the ones, they're a nonprofit organization based in Richardson, Texas, and they are the ones that developed the Speak Out program. This is actually from their educational series, this actual slide. And so they are, they know that this program works so well that they actually offer across the United States workbooks. It's on a pay-it-forward system, so they provide all your supplies as well when you start this program with a speech pathologist, and it's a pay-it-forward system. But they do operate out of Richardson, Texas. I just kind of want to give credit to them because through their grant, that is how we have all been trained so that we can reach more people across the United States with Parkinson's.
Great, we have time for one more question, so perfect.
Just because your spouse has been complaining that they can't hear you ever since you've been diagnosed with Parkinson's 14 years ago, doesn't mean that you have a speech problem. But to keep peace in the family and to be able to continue the dialogues for all the activities of daily living that make it possible, you've got to do something to learn. And this looks like an effective way to do it.
I appreciate that comment, and I want to echo that I have seen individuals that have the diagnosis of Parkinson's and they have not opted to do therapy. And then I've seen them again 3 months later or 6 months later, and they are communicating just as well. That's where we get to have this conversation with them about what is their priority with their time and their energy in life. And I love that. We get to be a part of the conversation, offer our expertise, and help you live your best life with intent.
And some of the training we do at that diagnostic level is also for the care partner, because communication takes two, right? You got a listener and you got someone speaking. So there's a lot of training that we do with the care partner as well on how to help support their individual or their loved one with Parkinson's, and how to encourage them to keep maintaining that voice, right? And to keep that communicate, because it's frustrating, right? The most frustrating thing in the world is when I have to repeat 5 times to my kids to do something, right? It's just and it can get frustrating. There's so many other things that, are going to frustrate us that we can't avoid and that we can't do anything about. So this is one small part where we hope we can intervene and help not only with the Parkinson's patient, but the caregiver or the family as well.
And one thing I want to add is that communication is paramount to us for all of us being human. You got to be able to say what you need to say and people understand it and hear it. Because once you give up your voice, or you don't have a voice, or you don't use your voice, people don't talk to you anymore, right? You lose a lot of power. There's a lot of power in communication. And if you don't talk, people say, well, how is he doing? And it's like, I'm right here, talk to me, right? But if you don't speak and they can't hear you, you lose a lot of ground. So our whole job is to keep you in the game so you can make your own decisions and be heard. Oh, go ahead.
You can't close any better than that. That was wow. Yeah. Thank you. It is 11 o'clock on the dot. We're doing amazing. Right? Thank you again. That was very informative and really appreciate it. Thank you.